Hello and welcome, everyone. We will get started in just a moment. So excited to have you with us this afternoon, evening, depending on which time zone you're in. Do drop in the chat where you're joining us from and what brought you here today. That we'd love to know who we are spending this time with. And we'll get started in just a moment. Again, thank you. I am so excited for this workshop and to be among this amazing group of panelists. First, I want to introduce myself to those I've not met. My name is Marie Boone-Clark, and I'm founder and executive director of Birthing the Magic Collaborative. We are a 501c3, and our work is around curating platforms like this, but then also perinatal and parenting education. The impetus behind this workshop and having these amazing leaders from across the country is that we wanted to give our audience an opportunity to meet some of those people who are doing some incredible work to address not only health inequities in a broader context, but within the context of Black birthing people. And Safer Births is an initiative that we are humbled to partner with so many organizations to bring to you the week prior to Black Maternal Health Week as an effort to educate, empower, and all those good things. Some brief bios for our panelists. Dr. Q English is a national faith leader and advocate. She previously served as director of the Center for Faith-Based and Neighborhood Partnerships at the U.S. Department of Health and Human Services, and she is now president and CEO of Elevate Health. Also joining us is Dr. Leslie R. Walker, who is a nationally recognized adolescent medicine specialist, and she serves as chair of the pediatrics department at Seattle Children's, focusing on youth health and health equity. Dr. Alicia Harris is with us today as well. And for those of you who are with Birthing the Magic often, you know that she has become a wonderful friend to our organization. Dr. Alicia Harris is a board certified OBGYN. She is co-founder and medical director for Navigate Maternity, where she leads efforts to improve maternal health outcomes through innovative data-driven care. Dr. Audra Meadows is having some tech issues, and so we hope she'll join us, and when she does, we'll connect you with her. Leon Garnett, thank you, Leon, for joining us. He is a community health strategist and nonprofit executive dedicated to advancing health justice based out of Seattle and working very closely with Dr. Walker. And then lastly, and certainly not least, is Dr. Jeffrey Hines, who is a gynecologic oncologist. He serves as Chief Health Equity Officer at UConn Health and UConn Medicine. I know I did not say all of the things that all of you do. And so I want to give you each a few moments. And there's Dr. Audra. Dr. Audra Meadows is with us, and Dr. Meadows is at UC San Diego. And she serves as she's board certified OBGYN, public health leader, and she has a dual role both with UC San Diego Medicine and the School of Medicine. But I always say that I can say what's on paper, but that never truly covers the work that you all do and the impact that you're making in the community. So as our first round, and I will invite our audience to drop questions in the chat as we go along, comments, and we'll try to get to as many questions as we can. But I'd love for each of you to share with the audience what made you take this afternoon to join us. And then I will turn it over to Dr. Harris, who's going to frame the topic and then lead our conversation. So if you could just take a minute and share with us why the work that you do and why you're here today. Dr. Walker?
Good afternoon, everyone. So yes, I'm Leslie Walker. I have two roles. I'm the chair of the Department of Pediatrics at the University of Washington, and I'm also a senior vice president and chief academic officer at Seattle Children's. And my homework in pediatrics has always been adolescent health. So maternal, child health, development has always been something very important, and young women having choice. But in this space, one of the things that I did when I took over 6 years ago was really look at how can I blend children's and the University of Washington, which are two separate entities, in a single area. So one of the things that I did was created with the chair of OB-GYN at University of Washington, what we call the Health Equity Institute for Healthy Pregnancy, Children, and Families. And the main goal of that was to have the community identify what they needed from us. And then, we have a huge research, implementation science, all of those kind of things, capacity building ability. And, so what could we bring to bear to help answer and work with the community? And one of the first things that has come up that we've been working together on is Black doulas, Black women having concordant Black doulas. So I'm here today because I was really excited to get to be in a room with others who are focused on Black women's health. And I look forward to today.
Thank you, Dr. Walker. And I'm excited to have you. Dr. Hines?
Thank you again. Jeff Hines here from Connecticut. I'm Vice President of Diversity, Equity, and Inclusion for the University of Connecticut and for UConn Health. I'm here, like many of us are, to talk, brainstorm, strategize about during these very volatile, these uncertain, these cruel, and these ambiguous times, how we can continue to do this work and talk about how we can prevent this process of erasure that is going on. So I'm very excited to brainstorm with each of you today as we navigate these very challenging times. So thank you for the invitation. I look very forward to the conversation.
Thank you, Dr. Jeff. Dr. Meadows, Robertson Meadows.
Hello, everyone. I'm also very excited to join. My name is Audra Meadows. I am an OBGYN professor and vice chair of culture and justice in my department here at University of California, San Diego. And, as you said in the introduction, I sit at the intersection of public health and clinical medicine here in San Diego County, where I work to make sure that doing things like exactly what we're doing now, collaborating and thinking of the continuity of care for individuals is really important. And more so now, to just what Dr. Hines said, in these times, more so now, more important that we have a very comprehensive, supportive system in place, because we do understand that a lot of the challenge we're seeing, particularly in my field and maternal health, when we see those disparities related to the outcomes of birth for Black women, we've got to continue to make sure that science prevails over innuendo and rumor, and make sure people understand that the reasons why that happens is rooted not in individuals and their behaviors or in their genetics, but rooted in our systems of care. And when our system of government is starting to collapse around us, when our systems of economic stability are collapsing around us, we have to make sure that we hold up the pillars of our system of healthcare, because we don't want those to continue to collapse around folks and making everybody even more vulnerable than we're finding ourselves in this current environment. So thanks for having me.
Powerful, powerful statements. You guys are going to have me doing, I told someone the other day that people don't realize my dad was a Pentecostal minister, so I've got that amen inside. Leon, could you share with our audience what you do and why you're here today?
Thank you for having me. My name is Leon Garnett. I'm the Director of Community Partnerships and Operations for the Health Equity Institute, and I have the privilege of working with Dr. Walker. In my role, I primarily work with community-based organizations and other stakeholders to establish priorities for health equity programming. As Dr. Hines said, we're in a time where collaboration is going to be key, and we need to make sure that our programming is permanent and durable to withstand everything that's coming towards us. So I'm just thankful to be here and to listen and learn from all of you. So thank you again for having me.
Thank you, Leon. Dr. English.
Hello, hello. So in my role, thank you again. Thank you for bringing us all together. But in my role as president and CEO of Elevate Health, we address the social determinants of health by connecting faith and community-based organizations to services and resources in an effort to improve public health outcomes in their respective community and region. And as the creator of the Thrive Tour, we're working to shift the maternal health from crisis response to community-rooted prevention. And we do this by addressing the root causes of inequity, not just what's happening in the delivery room, but what's happening long before and long after birth. And so the Thrive Tour is a national movement that brings resources, policy engagement, culturally informed mental health support directly into communities, especially where access has failed for Black and Brown women. And so through faith partnerships, through doula support, public-private collaboration, we're building models that don't just treat, but transform. So it's a 20-city tour that's targeting in areas that have high maternal mortality rates, and we're looking to connect pregnant and postpartum women and families real-time on-site with the services they need to thrive. And so I'm really excited about being a part of this conversation and being a part of this village until the U.S. becomes one of the safest places for women to give birth. Thank you.
And last but not least, Dr. Alicia Harris. Share with the audience why you're here, what you do, why I'm such a fangirl. And then I will let you all know that Dr. Harris is going to take over as moderator because I told her, I said, I have admired these people for many, many years. And you know, y'all get excited about Beyonce. I get excited about this group. And just like how you couldn't talk to Beyonce, I can't talk to them. So we're going to let Dr. Harris be the moderator, and I'm just going to sit here and fangirl. I may even turn off my camera so I can take notes and get excited. But Dr. Harris, thank you.
Awesome. Thank you so much, Marie. Again, I'm Dr. Alicia Harris, and I am practicing clinically as an OBGYN hospitalist at a perinatal center of excellence. So I see clinically a lot of acuity and a lot of volume in Indianapolis, Indiana. And then I also am a co-founder of a startup. It's called Navigate Maternity. And serve as the chief medical officer, where we utilize medical technology to empower patients, to collect data, to improve advocacy for themselves, and to improve their outcomes. And so I can talk a little bit more about Navigate Maternity later, but I also am involved at the legislative level, being the vice chair of the American College of Obstetrics and Gynecology here in Indiana. and also on the National Legislative Committee, and annually attend the Congressional Leadership Conference that we just had most recently in DC in March, where I work with ACOG and our legislators and advocate for the introduction of bills to benefit women and children. It's a passion of mine, it's a frustration of mine, but somebody has to lead the charge. So I am very passionate about improving maternal outcomes from every facet, every lens, every avenue I can. And so I feel completely honored to be able to share this platform with you all, and love to hear what we all are doing so that we're no longer working independently in silos. How can we exchange ideas? How can we exchange collaboration? How can we unite? As a united force, I think that we can push the needle on health equity. So again, excited to be here. And that will lead me with my first question. Can each of our panelists please tell us, what exactly are you doing at your institution to push the needle to improve health equity for maternal outcomes?
I'd love to jump in, just simply because also Dr. Q English is on the call. And so one of the things that we're doing together in San Diego is we reached out, we were honored and excited that Dr. English accepted our request to be one of those cities on the tour, because we do recognize that change, we know, does not come from within, it comes from outside. And for that to happen, for us to have, you know, community partnership and our patients and our community members engaged in the work that we're trying to do at the healthcare system. And I won't speak, you know, about the work that I do. I can say more about that later in terms of quality and accountability within healthcare systems. But really what's important, and more important now, when we used to think that health fairs were cute, fun things to do on a Saturday to go get a stress ball and take home a couple of, you know, hand sanitizers, now we know it's extremely important in order to make sure people understand the kind of care they need and what kind of care they can get and services. And so we're really thrilled to have Dr. English and her team come and work with us in San Diego County to ensure that we can do that in San Diego. And I can let Dr. English say more about the transformative work that is to partner with our healthcare systems and do this kind of work in the community.
Yeah, I guess I'll just pick up from there. When I was in federal, I directed the Center for Faith-Based and Neighborhood Partnerships at HHS. And one of the things I launched there was the Moms Tour, where, you know, it was important for me to let the officials know that if we're going to be effective in this movement, we can't think that they're going to read our media advisories, our press release, our and even, you know, some of our emails. I said, we have to go to community that needs the care most. And I said, I would love to start with a 25-city tour. And they said, boy, that's aggressive, Dr. English. I said, yeah, because we're aggressively dying. Next question. And so, you know, when you think about it, it's critical that we show up in communities. And that's what we did. We showed up in communities. And if we're saying suicide and substance use disorders are the leading cause of death for women postpartum 6 to 12 months, Black women preeclampsia and other conditions, and if we're saying that CDC, that doulas and midwifery services help improve these outcomes, and if we're saying we're lacking the culturally competent doulas to really tend to our Black and brown pregnant and postpartum women, then we need to connect them. We need to build that village throughout our nation in the cities that need it most. And that's what we did. So we bring together doulas and midwives. I'm so excited about being with Dr. Meadows in San Diego. And so we bring together the doulas and the midwives and the mental health specialists. And so during that time, and I can say that we were honored by the vice president for the work that we did in that space, but we connected over 20,000 pregnant and postpartum women to services real time on site, including dads, because it's not I'm pregnant, it's we're pregnant. They had their own private den of talking through their suicidal ideations, et cetera. They had educational components where the midwife would talk, the doula would speak, OBGYN will talk about what they need to pay attention to in their bodies when it's urgent to see the doctor. And then my last statement there was like, if you keep telling the doctor what you're suffering with and they're not listening to you, then fire the doctor. And so then we also talked a lot about educated them on the postpartum depression side. And so it was an educational component, it was resources, it was introducing them to a village, which is what we're doing on the Thrive Tour that's coming to San Diego, introducing them to the village to help improve their outcomes. And so for me, that's a very, very exciting part of the work that we do. We're now tagging on monthly mental health care for pregnant and postpartum women. And so that's an exciting part. And then we're also offering extended support for fathers, so once they're in that dad center, it's not the last time they're going to be there. So we have fatherhood programs that teaches them how to be a support, not only to their significant other, but also to themselves. So I'll stop there.
Hi, I think one of the big things to me being in medicine and understanding that our healthcare system is at its base built on racism and inequities. It's very hard to turn. People have been trying to do some of the work we're doing, right, for 100 years or more. And you see no change. And in fact, people are worse than they were in the past. And so, when you're trying to think about how can you make a change and who needs to be more elevated, one of the things that Leon, and he'll talk, I'll have him talk, he can talk more in detail about some of this, but one of the things that's always been very clear to me is that the community knows what they need. You live there, people are not ignorant of what is happening to them and their family members. And, so how do you put that first? And then how do you just use this academic machine as a tool for that work? And so we spent, I don't know, he'll tell you, but it's probably been almost a year, 2 years, really, not trying to go in, not getting grant. We actually have had a number of grants we come across the table and have not wanted to work on them till now, because I think we're now at the space because we didn't want to be writing grants. And so, we can write grants. It's academic institution, that's what we do. But when you do that and you don't, and you just ask people to be a part of it, it's not really the same as the community saying, hey, I heard there was a grant. Why don't we go for this and see what we can do? Can you help us with this, this, and this? And so it takes a while. And so what we did in the beginning was just create relationships and work with people. And we have now a very strong relationship with the Black Doula Collaborative. And that began to percolate higher in the whole realm of maternal and child health. That really percolated. And there were people that wanted to help fund us to look at how can we improve the 2 times higher death rate of Black women having babies in this area than white women. How can we make a difference? And so, it turns out there's some people in OB who are interested in the same thing. So we brought everybody together. It's clearly not my area of expertise, being on the other side of the child side, but we brought people together that needed to be together. And it's really over time been working out really well. We hope to measure, of course, and see if you have a concordant doula, does that make a difference? Now, just with our voices being completely silenced in the healthcare system, I would expect, there's some other research that would say that this should be helpful because you have that other voice there helping. For me, it's kind of personal in the sense one of my friends who was a college colleague of mine that lives here, his wife died, in childbirth, and for no good reason, died the day after childbirth, suddenly, and could have been prevented, right? So how do we make sure that these things don't happen anymore? And how do we help the doulas who, in this state, there is payment for doulas, but, how it's low. And so Black doulas don't stay long in the field because they're not getting a living wage. So how do we help create capacity, get them the statistics they need and the help they need to go to the state and say we need a higher rate? Those are the kind of things that we've been working on within the direct maternal health arena. But I'd love Leon to talk a little bit more. An academic institution that already has a reputation, as well as the Children's Hospital, for not necessarily being a place of comfort for people of color. It takes a little bit to begin to have those relationships be authentic. So I don't know, Leon, if you wanted to talk more.
Yes, thank you. So, as Dr. Walker said, we spent about 2 years really just getting to know our community and letting them get to know us. It's really important that we stress that we wanted to be supportive, not extractive, as so many institutions can be. I think that's, often the nature of the interactions between institutions and community. And what we learned from our community is that they really wanted support around maternal health and doulas. And so we worked with our community partners. We're working with three community-based doula organizations and a host of independent doulas. And we set up a program that we've called the Collective that's being implemented by a Black midwife at the University of Washington. And this program study has three areas that we're focusing on. The first is what does culturally competent care look like for those who can pay or not be able to pay, who are receiving services at uh, UW Medicine. The second part is um, what prevents doulas from staying with their clients through the delivery process. We know that there are a host of policies that prevent doula access and some really interesting policies at UW Medicine as an institution itself. So we're working with the leadership at UW Medicine to understand how doulas can have more access. And the third part that Dr. Walker alluded to was just the career span of the lifespan of careers, doulas' careers in Washington. We heard from our partners that it tends to be 5 years. We know that there's not enough doulas uh, to serve everybody who needs them. And so we've been working with the birth worker community to understand, okay, what can we do to keep you into this career? As Dr. Walker mentioned, in 2022, the doulas were approved to receive Medicaid reimbursement here in Washington, but that has still been sort of an arduous process for them in terms of how they bill. Is the wage enough? Um, being in the Pacific Northwest, there is a lack of training that the doulas wanted to participate in, and traveling to other parts of the country can be expensive. Also just community level capacity in doing this work and being able to organize. And so those are the three areas that we're looking at with our doula partners, and we're making good progress. We are in the implementation phase of the project, and we've been getting really good feedback from our community partners. So I think we're on the right track in terms of being able to really support the birth worker community as we move this project forward.
I will probably end this first question. It's been great to hear the responses. I'll start by saying, certainly our healthcare system is acting the way it was built. So there's no surprise that these disparities exist. We've developed a very matrix format for how we're addressing this. So one part of our strategy is what's the infrastructure that we need to build and how does it impact people? And then we further subdivide our work into what are the place-based initiatives that we're doing and need to do, and then what's the system level work that we need to do. So from an infrastructure perspective, many of you are likely ahead of where we were. So the first thing we did is we wanted to be data informed. So we built very powerful dashboards to help us track how our patients were doing. I'm a firm believer, I think as many of you are, that safety plus quality equals equity. And so we applied the same lens to the safety quality dashboards that are already built to one around equity that specifically looked at, mortality is a horrible thing, but we also wanted to focus on morbidity as well too. So we were very intentional in the data dashboards that we built, number one. And then in terms of how we interacted on the people side of things, how are we going into community with humility? How are we going into community with the ability to have some wraparound services and other investments that we could make that would help us with the relationships that we were building? And then once we did that, we decided to do a bit more of the system level work in. So similar to what Leon was saying, there was an opportunity in the state of Connecticut to get in on the ground level around specific, consistent training for doulas. And so we're hoping that's going to end up in some legislation. And then also, what does a bundle of payment look like for our doulas and for our OBGYN physicians that take care of Medicaid patients as well, too? So there were a couple of lanes of work we were doing on the state level. And what was wonderful is we were able to bring other partner health systems into that conversation to help us drive that work. So that collaborative spirit among other health systems to do the work was very helpful for us in terms of getting on some of the legislative agendas here in the state of Connecticut. I'll stop there.
Dr. Hines, there is a question that was included in the chat about something that you just proposed. Can you expand upon what you mean by a bundled payment for doulas?
Yeah, we were looking at through Medicaid, we were looking at that care that is provided from the first visit, and actually we wanted to expand it through the first year of the child being born, because the doulas in our model would also be involved in some of that first year of life care for the child that was born, in addition to continue to have a relationship with the family. Someone had mentioned before, it's not just the mom, it's the family. But we wanted to create a model very similar to, many of you are likely familiar with family nurse partnerships that exist, where sometimes those nurses or those nurse practitioners are actually in families for up to 2 years. So we wanted to create a model similar to that in the state of Connecticut and see if we could get it paid for as well. So that's what we are defining as a bundle.
I wanted to chime in when we were on the tour, we have certified almost 600 culturally competent doulas across, the nation, namely Black, and a few men. They call themselves doulos. And there are, just looking at this, the question in the chat, doulas should be considered. There are challenges, if we could be totally transparent, with the fact that Medicaid is not quick on that reimbursement process. So that is what I've been hearing around the nation, is the timing of the reimbursement, right? They could have provided the service and they're still waiting for their money. And many of them don't know how to navigate that system. And so there are now, I'm working with the doula organization that is teaching them how to navigate the Medicaid system so they can get paid. So there are challenges there, but on the Thrive Tour, we are offering free certification for doulas, up to 10 to 15 per city. And so that is another way of us expanding the perinatal workforce, in addition to assuring support for some of the women that may want it. And so doula is a very, very important part of the equation, as well as the home visiting nurses, et cetera. All of those things have to work together. That whole holistic model of care, the OBGYNs, it's all necessary if we're going to really make a dent in this atrocity.
Okay, I make 2 comments, Dr. Harris. Just one about the doula care. So I see a lot in the chat about the doula care. Just wanted to share that in some hospitals, our hospital is one of them, there we have volunteer doula programs. And so if you have a hospital with that, that takes away the cost related to that. And so I think that's really important. Interestingly, the other thing I'm going to say connects to the other comment in the chat about person's voice and listening to people who are most impacted and affected. Dr. Hines mentioned having a dashboard, and it's something that a lot of hospitals have been working on and creating, and we have one as well. When you use that dashboard to think about quality and accountability, and you disaggregate by different groups, by demographic, whether that's race, ethnicity, language, et cetera, you can see who's most impacted in that regard. And that's some of the ways that we think about what are some of the languages we need covered in terms of making sure that not all our volunteer doulas speak English, but that they speak different languages to serve all of our population. But to your point, interestingly, those dashboards don't always allow us to get in the narrative information back from patient experience in a way that speaks specifically to obstetrical care, if we're talking about maternal health across all of reproductive health. And so we are working on that now. We have a pilot project out to do something where we're using the Madam and Maury, which are these two particular surveys to listen and learn about the experience of respect and autonomy in their care. And so hopefully we'll get more of that information back that'll continue to bolster what we're trying to work on. So I really appreciate the comments that people are making about, do we take person's voice and making sure that we're centering what people are experiencing and going through in the work we're trying to craft and construct. And I would say that many are. It's just not the easiest thing to do in the healthcare systems that aren't set up to get that information back.
I think this is a great segue to the next question that I have for all of our panelists, especially, in this precedented time period that we're all trying to day by day navigate the changes that are, being thrown our way. How do we best facilitate trust in bridging the gap between the clinical setting and the community outreach programs that we're kind of leading the charge for? What are some strategies to overcome the patient mistrust of our current clinical systems?
I can speak to that if I can. Our approach has been to try to be really transparent with our community partners and again, not be extractive. I think for a long time I was on the community side and I would have universities or government come to me and saying, this is what we're doing. And it would be, the power imbalance would make it hard for community partners to fully participate. Or in some cases, it would even cost us to participate in these programs and the partnerships wouldn't last and be fruitful. So I think to have long-lasting, trusted partnerships, we as representative hospital systems have to be really intentional about the type of relationships and partnerships we create. We have to make sure there's a good organizational fit, but I also think we have to focus on mutual benefit and be as invested in our community level outcomes as we are in our partners' outcomes and success. And so that's what's going to keep the partnerships going and make them really durable and keep our partners coming back to the table. So that's what we've been working on at the Health Equity Institute, within our area here in Seattle, is really making sure that our community partners understand who we are and what we're about, and we know what they're about, and that we are aligned in moving forward. And it takes a bit of time to build those trusted relationships, but once they're in place, we nurture them and they're long term. We're not building transactional relationships here. We are invested in our communities. And I think, in our area, that's what our partners have asked for us. And so that's how we're moving forward in our work.
I will add to that, that how we were able to get started is both the CEO at the Children's Hospital and the CEO and Dean at the university gave us resources to get started. So we didn't have to depend on a grant to get started and get working in the community. And so they were invested as well in our vision of what we thought was missing within our relationships within the community.
And I want to piggyback on that. I always say true collaboration happens when community voices are treated as equal expertise at the table, not asking them necessarily to sign off on a pre-drafted document or after a grant is written, but from the ground up. And so you got to be able to build bridges between hospitals, public health leaders, faith-based organizations to co-create solutions with, not for, community.
I want to just also add to that and agree. I'm in academic medicine as well. So there's so many different places, spokes on that wheel, I would say, for trust building. And so as I think about the work that we do with community partnership, is what all's been said, the bidirectional approach. In my role as the vice chair of my department, it's culture and justice. And what we're trying to do is build a culture of equity and social justice in everything that we do. And what we're doing with the community outreach that we do in that particular spoke it's just meeting each other. We don't even stand in the same rooms and break bread and talk without there feeling like there's already a power dynamic, and often in those, a lot of spaces. So we're just trying to break that down. And we do that 4 times a year, just, as a number we chose, right? Because that's what we could attempt to do with the staffing resources we have. That's one of the things that we do, is just meet each other, just have conversations and know, but it has to be bi-directional. Just as much as we invite people into the things we're talking about in academia, we want to step out and talk and learn and see what our communities are doing. And so getting that voice back and forth. And like what Dr. English said too, we're working on grants together with some community partners, human-centered design and co-creation from the very beginning all the way through, not pre-prepared documents that we write with our grant writer and then come and get, a rubber stamp. So those are all important. I'm going to say those things slow down the typical work. We are working uphill against dominant cultures. The dominant culture of medicine and academia is not one that is typically catered to that pathway. And so when you create those pathways, things move a little bit slower. And the thing I like about this pathway, though, is it creates a personality. I like for people to meet our healthcare system and our OB/GYN department before they get sick, before they have to come to a hospital. Know who we are and who I am and who the different folks are, just as who is a personality and have a face and a name. That's really important. So important for a number of things. Something it's also really connected to, but on the clinical spoke, is transfer. So for instance, in Southern California, we have a lot of out-of-hospital births. And a lot of times when people are attempting an out-of-hospital birth, particularly when you've got maternal mortality rising, morbidity on the high levels, you don't know which double doors to walk through to get the same opportunity to have a great birth outcome as some other hospitals. You're not really sure. You see what's in the paper. So people will increase their numbers of wanting out-of-hospital births. But at times, transfers need to happen. When transfers need to happen, you need to know who those folks are too. Those are our community partners as well. And when those relationships aren't there, it makes it a little bit more awkward, a little bit more difficult for everyone. And when a person's giving birth, they feel it on their way into those double doors. So we work on a lot of those things. So the ways we approach it, though, are very structured structured approaches, which are safety bundles. So the California Maternal Quality Care Collaborative, we have an equity bundle we're putting in place right now for an equity action guide. We have a community transfer bundle that just started, and so we're putting that in place. And I'll just end by saying one of the things I did when I worked in Massachusetts is I was the leader of our state perinatal quality collaborative work to put an equity bundle out. So someone also asked the question a moment ago, what would be a magic wand for me in my transformational space and thinking about equity and accountability through quality? Mine would be that every hospital system is set up from an infrastructure such that equity is just seamless in terms of making sure that we're always doing what is the best standard of care that we can offer, the best standard practice to offer, and that it doesn't differ by different folks, and that whatever is a challenge for offering the best care to folks, that people would want to receive that care as well, that whatever those challenges are, we found a way to overcome those and make sure that we've got that equity or equality of opportunity for everybody when they're coming through our double doors. And so that still doesn't exist across America. I really applaud things that are out there to try to help that, but we're missing some of those. So when you ask about what builds trust, that transparency and conversations are really important, but every single spoke on that wheel of where we're trying to do that, it could be a very different process and approach. And so I think a lot of us are working on many different projects to approach those in all sorts of different ways.
Just real briefly to co-sign all of that, we've been very focused on the actual language piece itself, and we've been very intentional about leading with cultural humility and not competency. Nothing against competency, I think, as long as people define it, but we have looked at competency as a skill and as a ceiling, and we want to develop humility and allow people to share their narratives to try to break down some of the hierarchy that exists. The other thing that we've started to lead with, again, the co-design, the co-create, the co-produce, but also trustworthiness of the organization as opposed to trust from the community, because we have felt very much that further victimizes a community to have them feel as if they have to do something when perhaps we need to do more of that work. So we've just put some intentionality around language that we're using as we're approaching relationships with communities.
There was a question in the chat that I found important to ask the panelists. So with thinking about all of this and being patient-centered, how are we engaging patients to improve health literacy within our communities and awareness about where things currently are. What are the maternal mortality review data in your state, so that patients are aware of what the risks are, how to advocate for themselves, and have better understanding of the physiology that could potentially affect them.
This is something we definitely address on the Mom's Tour in that educational component. So we lay out for that city where they are, as far as their report card, we do rely on data from CDC as well as from March of Dimes that is very clear on the ratings of these various cities that we're in. And we do that for the purpose of awareness, and so they can know what they're facing within their own community. And then we teach them how to advocate for themselves in healthcare settings. We do have like palm cards because sometimes you're just, so nervous because the doctors don't even allow them, and in some cases, to ask a lot of questions. They get a little bit frustrated. And so we give them a palm card and we teach them how to, if they have these symptoms, how to ask it, and then making sure that the doctors listen. And so that palm card wasn't created by us. It's a resource that was created by CDC for the Hear Her campaign that has been and it's translated in so many different languages. It has been very, very helpful for the women that have attended the Thrive Tour and families as well. So that's what we do.
Yeah, I'll just add on or say that, in inviting Dr. English's team to come to San Diego County, we also want to have a mindset of community practice so that as the Thrive Tours leaves, we still continue to spread the lessons learned and maintain them, and maybe even incorporate them into our system or incorporate them into the places where it makes the most sense. So, I'm a strong believer in training our future generations. We have a few public health students and residents and medical students who will be working on the evaluation piece and thinking about how we move that work sustainably forward across San Diego County, because we are a maternity care desert. And so it's a big deal, particularly for our neighbors to our east, which is El Centro or Imperial County, just east of San Diego County. And so those kinds of things are important too, as we know that when it comes and we have that moment, that's 3 hours, many more hours of planning, but 3 hours there. But how do we make those 3 hours last years? And so that's a challenge, but something that's on our mind. And I think that's an important piece of it.
I think one of the things with health literacy for me, it's always been a little bit of an issue because, in studies, the majority of the country is health illiterate, right? There's different degrees, but the majority of the country is health illiterate. Most people cannot read a medication. Most people, it's very difficult to read these things. And so we spent a lot of time trying to help people understand what's happening in the healthcare system, when to me, this is not a failing of people or information people don't have. It's a failing of the healthcare system to be actually approachable, transparent, and clear. And so to me, a lot of this is really should be focused on whatever we consider the healthcare system to become literate in being able to communicate with everybody else. So that's sort of my feeling about that, because I've been in so many meetings in so many different areas, and they're always talking about making the community literate. And when it's us, if everybody can't understand us, then it's us. And we need to deal with that as a healthcare system and as providers. I think the other thing that we're doing, or we're trying to do, like in terms of, we hear one of the statistics we know is that mental health compromise is a lot of the issues of maternal morbidity. And how do we help doulas to recognize that and to be able to help speak? There's conceivably a trust between the doula and the person. How can they better recognize that and help them either themselves, that sometimes people don't need full intervention with the mental health team, or how do they get to mental health team? So really helping them become competent or available, because they see it, but helping them, how do you address that with the moms you're working with, and helping the community as well with some of those things that you were mentioning, really be aware of some of the statistics. But I think the health literacy is the failing of the healthcare system, and we have to address it in that way if we want it to go away.
And can I also add, though, I also think that one of the things that made, 1950s or so America a superpower across other, developing nations is that we educated our entire communities. And so, our partnerships with departments of education, what we have left of one, right? And just health education across the country becomes really important in terms of raising health literacy. I mean, I think our partnerships there are really important because of the fact that, repetition is the best teacher of all. And if people are hearing these messages around their health, from young ages all the way through, then I think it makes it, when people finally meet us here in the medical care system, it becomes something that's more seamless. And I think it's something we can think about on a larger level. And I think, when we have strong organizations in our country that can help support that, then it works. And we've seen examples of that. And then in these times now, we can only imagine that health literacy is going to be a future challenge for us.
That's why the village is so critical. Village, the village is so critical with all the things that are going on now. I remember back in the day, village raised its children. We had a whole loaf of bread. I go down to my neighbors. I'm from Spanish Harlem, Carver Projects, and my mom would share the milk or we share the bread. I mean, we got to think in that community-driven, community-inclusive work, with what you're doing in your hospital settings, but being even more intentional to adopt the village concept in this climate, I should just say.
Yeah, I would say, the healthcare system, whatever from mental health to dentistry to medicine, has really tried to take ownership of all the information, right? And not really make it available. You have to go somewhere to get that information. And I do think working together across all systems would help break some of those. I think with mental health, it's begun to be broken because there's just not enough people to address mental health. And so they've got to figure out ways to get the information out, because you can't rely on having a therapist or counselor or a psychologist because there's not enough. And so they've had to, learn, how do you break that embargo on information for people. So.
I would love to chime in. One of the things that we've done in Arizona, where I'm based, is our, for those who are familiar with Postpartum Support International, it is an international organization that provides postpartum mental health support. Our local chapter secured a grant to provide the PMHC postpartum mental health counselor training to our local doulas. And we specifically worked with our Black Doula collective. So Black doulas across the state were given a complimentary scholarship to attend that 2-day training. There is a question in the chat that I'd love to pose to the audience or to our panel, and that is, how in your institutions are you tackling the preparedness of the ER staff to care for maternal health patients?
I can specifically talk about this. So this was one of the big ACOG asks at the Congressional Leadership Conference here recently. One of the things that we want to introduce or ask legislation to introduce as a bill is an act to better prepare these hospitals that are in these maternal health deserts, where there's not a single OBGYN provider or a maternity ward in the entire county, and equip them with telemedicine, one, so that they could contact an OBGYN at another location to ask them, how do I deliver this breech baby that just showed up here in the ER? And then also to supply them with the tools that they need to take care of these patients. If you don't even have the ability to monitor a fetus, how do you know if a fetus is in distress when this woman presents to the ER? And so, having the equipment, having the knowledge, we realize that there is a clinician shortage. Currently, we're about 8,000 OBGYN short. And where I practice in Indiana, a third of our counties do not have a single OBGYN. And I know in states such as Georgia, that disparity is even worse. And so it's really an important matter that we need to address. because with legislation, there's even more barriers and more people leaving clinical medicine out of frustration. And so this is only going to continue to rise. And so it's something that we definitely have prioritized with American College of Obstetrics and Gynecology and are really working hard to advocate this point to our current legislation.
Thank you, Dr. Harris.
Yeah, I'd also add, this is also some of the work of AMA COG as well, which are their safety bundles. And so in the work of looking at each of the safety bundle, there are these R's: readiness, recognition, response, reporting, respectful care. And the thing is this readiness and this recognition piece are important because some of the issues related to morbidity, and actually I would probably, sorry, let me say it differently. The issues related to morbidity are about time, recognizing the challenge early enough to be able to intervene and offer these life-saving treatments. When people are dying in maternal care, it's not because of things that we can't treat. It's because we aren't getting folks the right treatment in the right amount of time. We want to give the right amount of treatment, not too much and not too little and not too slow. And so those are the things that save lives. And so with safety bundles, if we have a way that we offer best practices across all hospitals, and we're assessing whether or not all hospitals are always up to date on offering those best cares, and we're doing our jobs, and that includes collaborating with different departments in the hospital system, like the emergency departments, and collaborating with the folks that release the blood, so the blood bank, right? The emergency room, the OB department, the other folks that, in Dr. Hines's field often come to the obstetrics wards to help do, more complex surgeries if we need to. Collaborating with everybody, general surgery, to make sure that when things are happening that need an immediate response, you can do that. And so there are some pathways there, but not all hospitals are participating. And then to Dr. Harris's point, even when you've got all of them participating, when you've got these big gaps in space, where people can go present for care, it's an issue. But safety bundles do a lot for that. And so if your state, is pushing for advocacy and legislation to support quality and safety through perinatal quality collaboratives, then that's something to really support as well, to ensure that readiness is something we've all got on the ground.
The readiness piece also includes, something that we all are aware of, but the biases that exist when women of color or Black women present even to those institutions that are well prepared. We actually happen to be in a state in Connecticut several years ago. There was an initiative around legislation that was passed and signed by our governor that racism is a threat to public health. And buried within that legislation is that all units within the state of Connecticut that take care of women need to undergo implicit bias training. Now, there was nothing within that legislation that talked about how that was going to be enacted, how it was going to be enforced. But I still think, yes, those bundles are critically important, don't get me wrong, but there is some ongoing work that we need to do when women are coming into labor and delivery and are ignored, erased, and dismissed, and when they come back in the postpartum period, when they're ignored, erased, and dismissed as well, too. I think that's an important piece of the readiness that we need to make sure we're continuing to drive forward.
And I know we only have 2 minutes, but in that 2 minutes, I've lost my shyness. I do have a question for you, Dr. Jeffrey, and Dr. Audra, simply because your states have both, I know Connecticut and California have mandates for practitioners to take anti-bias training or to have that education. How are you navigating that in today's environment where we have our federal government saying that is no longer required, or actually you'll be penalized should you do it? How are you navigating in those waters without being too specific to your respective organization?
Sure, I'll be real brief. I live in a state where I can say the words diversity, equity, inclusion, and disaggregation still. And because this is a state statute, it's baked into the fact that we have to work out the details of enforcement, but we can still do that because it's a state statute. Now, we don't know quite what's going to happen if the federal government starts to leverage some of their power around withholding federal funds even to a state, but at least at the surface of it, because it's a state statute, we're able to insist and have organizations do that mandatory training.
Thank you.
Yes, I'd say the same. In the state of California, we've had some regulations since the 90s or maybe even 80s that have been in place that sort of match what folks are trying to go for now. on a federal level. So, when it comes to this concept of people feeling and fearing that other groups of people are making it to the front of a line or being preferentially supported when others shouldn't be, that's not the goal. It's never been the goal. And it's not what DEI is. DEI are three different letters that, stand for three different words that have three different workflows and processes to get there. And so luckily I am part of a system and part of a state where I can continue to work in that area, and not just those three letters, other letters, other that we're trying to do. We want to make sure that everybody can go into a hospital system and feel seen, heard, and valued, and cared for in a respectful way. And that in doing so, that they feel like they matter as much as anybody else coming through those doors. And that the financial part of this is important too, like their insurance or what people are paying for their healthcare. Each person's paying, yet, equality means we give everybody a discharge summary, and equity means we give everybody a discharge summary in the language that they speak. And I'm just firmly rooted in the idea that if you're going to come in here and we're in a healthcare system in this country that's rooted in economics and not rooted in public health, then when people are paying for a care and a service, they should get the care and the service, that they're asking for, which means, talk to me in the language that I'm speaking because of the fact that they paid for it. So that being said, I'm happy that I'm still able to do that and really just lean into what Dr. Hines said. If we don't know what's going to happen, so we're going to do what makes we're going to follow regulations. We're going to do what's safe. That's number one in the healthcare system, is doing what's safe and not putting anyone in danger in any sort of way. We want to improve and elevate and optimize the experience of maternity, safety first, in addition to all the other experiential pieces.
Thank you, Dr. Meadows. I can't think of any better way for us to have to end this conversation. I knew I should have booked an hour and a half, but I knew I couldn't get that much time from such amazing people. Thank you all so much for joining us for this workshop, for being part of this incredible discussion, your contributions. If you looked at the chat, our thoughts are running rampant, and there's so many ideas. And thank you for the time and energy that you invest in making such a meaningful change to our community. As a Nana, I'm not grandma, as a Nana and as a mother of two beautiful girls, I'm so very grateful that there are people like you there to support them. I'd love to ask you back. There's so much that we didn't get to talk about as a part two. And thank you to our audience for joining us today. We will have the recording available in a few hours or first thing tomorrow. It'll be on our YouTube. We'll send a link to you all. Thank you, Dr. Walker, Dr. Q English, Dr. Alicia, thank you for taking over when my nerves were in place. Dr. Jeffrey Hines, as always, thank you so very much. Leon, thank you for the work that you're doing. And Dr. Audra, again, always so very grateful for your support. And for those who are free this evening, join us for our ACT workshop for dads. We didn't even get to talk about the importance of fathers and partners, but I know Dr. English is very passionate about it. So for those of you who've not registered, we'll spend some time in that subject, and we'll see the rest of you later. Thank you.